Good day to everyone joining us, and welcome to today's X-Talks webinar. Today's talk is entitled, A New Statistical Method to Assess Treatment Benefit and Risk in Clinical Trials with Examples in Oncology. My name is Nima, and I'll be your X-Talks host for today. Today's webinar will run for approximately 60 minutes. This presentation includes a Q&A session with our speakers. This webinar is designed to be interactive, and webinars work best when you're involved. So please feel free to submit questions and comments for our speakers throughout the presentation using the questions chat box, and we'll try to attend to your questions during the Q&A session. This chat box is located in the control panel on the right-hand side of your screen. If you require any assistance, please contact me at any time by sending a message using this chat panel. At this time, all participants are in listen-only mode. Please note that this event will be recorded and made available for future download. At this point, I'd like to thank IDDI, who helped to develop the content for this presentation. The International Drug Development Institute is an expert center in biostatistical and integrated e-clinical services for pharmaceutical and biotechnology companies in several disease areas, including oncology and ophthalmology. IDDI optimizes the clinical development of drugs, biologics, and devices thanks to proven statistical expertise and operational excellence. Founded in 1991, IDDI has offices in Belgium, Boston, Raleigh, and San Francisco. Now I'd like to introduce our speakers for today's event. Mark Boyce holds a Doctor of Science degree in biostatistics from the Harvard School of Public Health. He is the founder of the International Drug Development Institute and of CluePoints, two biostatistical service organizations based in the US and Europe. He is interested in clinical trial design, meta-analysis, validation of biomarkers, and surrogate endpoints, statistical methods in oncology, statistical detection of errors and fraud, statistical monitoring of clinical trials, and medical data sharing. Everardo Saad has over 15 years of experience in medical oncology and clinical trial designs. He graduated in medicine and trained in internal medicine in Sao Paulo and did his fellowship in medical oncology at the University of Texas, MD Anderson Cancer Center in Houston. After practicing for several years, he shifted his professional career towards education and research in medical oncology and has a special interest in clinical trial methodology, the assessment of endpoints, and the development of novel therapies for cancer patients. So now, without further ado, I'd like to share this presentation with our very first speaker. Everardo, you may begin your presentation whenever you are ready.
Thank you, Nima. Hello to everyone. Thank you very much for attending this webinar. So our plan for today is as follows. I will start by introducing some of the measures of treatment benefit that are available and currently used in the literature. And then I will say a few words about the current attempt to individualize decision making. So I'm going to describe, let's say, a problem to which Mark will then come and try to propose a solution. And the solution we're discussing today, one of the possible solutions is a method that has been developed called the Generalized Pairwise Comparisons, or GPC. So Mark will talk about the method, how it works, how it can be used to prioritize outcomes. We'll focus our presentation in oncology, but as Mark will explain, this can be used in other fields. And then Mark will say a few words about a more technical statistical issue of using GPC in the setting of non-proportional hazards. So let's start by focusing on survival, because like I said, this is our focus today, oncology. But the method can be used to other types of endpoints. But most of the examples we'll use today will involve survival in some way. So let's start by looking at this, let's say, idealized survival curves comparing two treatments, each one represented by a color. So we see survival probabilities over time, as we're used to seeing in Kaplan-Meier curves. And of course, this is idealized because it represents an exponential distribution, which in fact we seldom see with real data. But let's use it as an example of the ways we can look at these curves to compare two treatments. So one of the ways is one of the versions of the so-called snapshot method is to choose any survival time of interest, let's say 6 months, and then look back on the y-axis to what survival probability this landmark corresponds for each treatment. And so we have a proportion of patient survival at in each group for this particular time point. So this is sometimes used. We can sometimes present data like this, especially for adjuvant treatment in oncology. But of course, this has some problems, one of which is depicted here, the fact that depending on which time point we choose, the difference between the survival probabilities when we compare the two groups will vary. So this will depend, of course, on the choice of this landmark. And so this is clearly subject to, let's say, cherry picking, if you will. And also it makes use of only one part of the information, whereas the survival curves provide much more information than that. So another version of the snapshot method is to reverse the, let's say, the axes and start here from the y-axis, look at the 50% survival probability and look at the median survival times for each arm. For example, here, almost around 2 months, almost 4 months in each arm. So this is very often done. It's very easy to memorize medians. Many people have them in their memories because it's easy to keep. But of course, medians also have problems. We throw away a lot of the information from the rest of the curve. The median can have other problems that we won't go into the details. Only one of which I will mention. The fact that sometimes, especially in second or third line therapy, and especially in the case of PFS, progression-free survival, which is depicted here, sometimes two treatments have very different effects. This can be measured, for example, by the hazard ratio. Whereas if we look at the median, they're very close to each other just because progression happens rapidly and it's not really captured by the schedule of assessment in clinical trials. So this is one of the reasons why medians may not be convenient, although there are many other reasons. We won't go into details. So obviously we prefer something that takes advantage of the whole survival experience. And in this regard, the measure that's more often used is the hazard ratio, which is really the ratio of the hazard rates for each treatment. So supposing the same idealized situation of exponential distribution, the hazard ratio would be constant over time. Of course, this very, very seldom happens in practice. There are many recent papers about this. For example, in this one, we can see that even though these survival curves appear to be relatively good in terms of being what we call proportional hazards, which means that the hazard ratio is constant over time. We can see that this is not really true. If the hazard ratio is plotted, we can see that it's in a way time dependent, and depending on where you look, it's really not a reliable metric in terms of really capturing the treatment effect over all the survival experience. So there are many situations, and Mark will mention something about that in his part of the talk, where hazards are really non-proportional. These are just 3 examples which are becoming apparently more common in oncology. For example, when there is an early survival experience, an early survival difference between 2 arms, or conversely, when the survival difference appears late in observation, for example, in some immunotherapy trials, and also when there is a fraction of patients that are cured in either one of the arms or 2 arms. Again, the hazard ratio is not a very good description of the treatment effect, just because it's not constant, and therefore hazards are said to be non-proportional. So we have seen the metrics that are commonly mentioned, at least in publications. One that is quite good in terms of its statistical properties, but unfortunately almost never mentioned, except for recent review articles emphasizing that, is the mean. So we don't often talk about mean survival maybe for historical reasons and others that we can perhaps discuss, but we won't go into the details now. The means are not very often used. One problem with the mean, with the so-called unrestricted mean, is that we would have to wait for all the events to happen. So the alternative in this case, to use the data and not a parametric estimation, is to use the survival curves up to a certain point, choose a so-called truncation point, and then look at the mean survival up to that point. And this can be done simply or computed simply as the area under each survival curve. So we would have here, let's say, a blue area, which is for the treatment that is performing better here, and then the pink area for the other treatment. And then we have these two areas, each one corresponding to the restricted mean survival experience for the corresponding treatment. And then we could perhaps compare these two means either by their difference or by their ratios. So we have seen some metrics. Which one should we use? In a recent paper, we put them together in terms of their advantages and disadvantages. I won't go into the details, but it's clear that they all have advantages and disadvantages. And in a few minutes, it will be clear that for the sake of assessing treatment benefit, they are not very good. So which metric should we use considering the ones that we have? That is the question. So let me introduce two examples about which Mark will speak in more detail, because he will use them to illustrate how the GPC method can be used to analyze trials such as these. So here's a situation, both trials were conducted in advanced pancreatic cancer, one comparing a chemotherapy with a targeted therapy, and another one comparing a monotherapy with a combination chemotherapy. And so these two studies were positive at the time, and both were published as such. But of course, we can see that the difference here is quite small, whereas the difference here is more pronounced. So we use these two trials in our review to sort of illustrate the metrics that I talked about now. So we could compare, we could look at these two trials and see how the hazard ratio performs, how the survival difference at, for example, 12 months perform, the difference in medians. For example, here it's clearly obvious that a 10-day difference in median is not something very exciting, even though the hazard ratio denoted an 18% reduction in the hazard of death, and this was statistically significant. And then we computed as well the restricted means for these trials. So like I said, all these metrics have advantages and disadvantages, and it's not very clear which one is better, probably none. And it's clear that we have to use probably more than one to have a full picture of any comparative trial, at least any phase 3 trial that aims at really comparing treatments. Now, how can we go a bit beyond clinical trials and think about assessing the work of treatment in general? I just try to summarize what I think we do. I think we do a formal assessment when we use generally statistics. For example, when we assess whether the trial is positive for the primary endpoint. Typically in oncology, at least, this is related to efficacy, but sometimes we may use quality of life or safety as primary endpoint. This is where we'll say whether the study is positive or negative, and we'll use this as where to look at in terms of assessing the work of treatment. But we can also look at secondary endpoints, sometimes even formally, although they will not define the study as positive or negative, but we can compute some statistics on them. And I would say it's another formal way of looking at the work of treatment is health economics, whether we use QALYs or ICERs or other measures of cost effectiveness or other dimensions of health economics. This is a formal way of assessing treatment benefit. And also there are informal assessments, I would say. For example, in a way, what agencies do when they try to balance benefit and risk. And the reason I call this informal is that because there are no ways to formally integrate the assessment of benefits and risks in the same metric, so to speak. And more, the assessment is done with issues about value in mind. And this is becoming, of course, problematic in many fields in oncology due to the price of many of the newer drugs. And this is particularly important in oncology. So much so that recently the American and the European oncology associations decided to create their so-called scales. They typically focus on value, the relationship between benefit and cost. Benefit can be really benefit or harm, like toxicity, so efficacy and toxicity, but there is the denominator of cost that is usually taken into account, although not necessarily in a formal way. So these scales, I would say, are a step in a good direction, but they do not really address the point that we're trying to address here today, because they predefine and assume a hierarchy within the endpoints. They ignore, let's say, potential problems with each endpoint. They use somewhat arbitrary cutoff points of magnitude, and they don't allow for individualized decisions. They are based on what we might call, from a statistical point of view, marginal results that apply to patients, let's say, on average, but you cannot say exactly what is the, let's say, the cross tabulation of the occurrence of these events on a per patient basis. So how can we individualize treatment choices? This would be really the question that I'm posing to Mark, who will step in shortly. So in my opinion, historically, what we have been doing is evidence-based medicine, at least for the past 30 years, I would say. So we use the results of randomized trials, sometimes subgroup analysis, to make decisions. So this is a giant step in comparison with what existed before, let's say even more than 30 years ago. More recently, there is this attempt to give the right treatment to the right patient at the right time, and we may call this precision medicine, as it has been called by many institutions and in many settings. And what we're trying to discuss here is, let's say, even one step further, which is, let's try to use precision medicine or evidence-based medicine, if you will, in a very individualized way, so that stakeholders can make decisions that depend on different views about the trial results or about the literature. So we're trying to move from precision medicine to personalized medicine, thinking that this is one step further. So this is my last slide. That's one of the third example that Mark will use in advanced pancreatic cancer. So let's suppose a patient is presented with results such as these. So this treatment, which let's call it combination, is superior to the monotherapy in terms of efficacy. This is indicated by various measures, but for example, by the hazard ratio for death. But at the same time, it causes more toxicity, and here we're just showing grade 3 or 4 treatment-related adverse events. So it's more than twice as frequent if you take the combination. So a patient might reason like this: well, if I take combination, I'm more likely to live longer, but I'm more likely to have grade 3, 4 adverse events, and we would have to agree with them. But then he can say, well, I'm willing to experience adverse events, but I would like to have a survival benefit of at least, let's say, M months in order to accept that degree of adverse events. So let's see if this can be tackled by the new method. And so for that, I will pass the mic over to Mark.
Thank you, Everardo. for the nice introduction. I would like to kind of step back a little and look at the situation that we are facing in randomized clinical trials from a sort of abstract point of view. So this is the general stage of the discussion I'm going to have. We compare in a randomized trial typically a treated group with a control group. And as Everardo pointed out, we generally designed the trial to meet what we call a primary endpoint. Typically in cancer trials in advanced disease, it could be the survival time of the patients, sometimes the progression-free survival of the patients, and in adjuvant situations, we might actually look at disease-free survival. But anyway, there is a primary endpoint, which we call A, and then we have secondary endpoints, and usually a long list of those called B, C, D, etc. And then, of course, also untoward effects of treatments and particular toxicities, which can be acute with very active drugs, which we call EFG, etc. So here is what we end up with. Conventionally, we compare the average outcome of patients for the primary endpoint in each group. If the difference between the average outcomes is statistically significant, we claim that the trial is positive. Otherwise, we claim that the trial is negative and we stop without regard to the secondary endpoints. The secondary endpoints are only looked at if the trial has met its primary endpoint. And so when indeed we meet statistical significance for the primary outcome A, then we hope that the results for the secondary endpoints will agree to some extent. And we also hope that the results for the EFG, the untoward effects, will be acceptable. And then we make recommendations based on, as Everardo pointed out, these marginal results. So we look at each endpoint in isolation, and then we decide if that endpoint shows a statistically significant difference between the treatment arms or not, and we make recommendations based on these marginal results. And obviously, in precision medicine, we also look for predictive factors, so that is fine. But there are limitations to this approach. As I said, the single primary endpoint drives the decision-making. If the study fails to meet the primary endpoint, the study is a failure. It's a negative study. And in fact, we can't really make claims, at least statistically, we can't reliably make claims about any of the secondary endpoints, which sometimes is a problem because the secondary endpoints might actually show a very nice benefit of the new drug or the new treatment. But unfortunately, because the primary endpoint failed, the study can't actually conclude. Endpoints are typically analyzed descriptively, except if we use some kind of tough and complex alpha spanning rules to divide the alpha level, the significance level between all the endpoints we look at. And then as far as safety, we informally balance the safety problems against the efficacy, and that results in risk-benefit analyses that are debatable. And the reason that they are debatable is that we take no consideration of the correlation between the endpoints. Suppose, for instance, that in order to get efficacy, you have to induce some safety risk. You have to have a skin rash, let's say, for a GFR inhibitor in order for it to be effective. Well, in that case, the patients who have the toxicity might also benefit from the treatment, whilst the patients who do not have toxicity would not benefit by from the treatment. And that would be a very different situation from one in which we actually induce toxicities in all patients and get benefit in only some. And that conventional analysis is not capable of handling. And then finally, as Everardo said as well, we seldom, if ever, take patient preferences formally into account. Obviously, informally, good clinicians will take patient preferences into account in deciding the treatment, but that, again, is an informal process, not one that is statistically driven. And specific to time to event endpoints, if I have the time, I will also look at non-proportional hazard situations. And the problem with multiple endpoints is that we use composite endpoint. If you think of progression-free survival, for example, that's a composite endpoint. It's a composite of the time to progression or the time to death, whichever occurs the first. So if progression occurs before death, the patient fails at the time of progression, and we take no consideration of when the patient will die. So the patient might die the next day or might die 10 years later. We wouldn't make a difference between these two situations in the analysis of progression-free survival because the patient would have failed on progression first. So in a sense, this is putting things upside down, because what we would really want to do is to consider the most relevant endpoint, in this case death, first, and then after death is taken into consideration, if the patient is still alive, then for a patient who's still alive, we would like to use their progression time if the patients have progressed. So in a sense, we want to change the order in which we consider endpoints, not by time, but by a relative importance or relevance to the patient. So I published a paper about 8 years ago on this approach, which I call the prioritized outcomes. So when we have several outcomes, we can prioritize them, again, not over time, but by the relative importance or relevance of these outcomes. And then in order to analyze these prioritized outcomes, you need to look at something that's called generalized pairwise comparisons. And so again, coming back to the general setup of a randomized trial, there are patients in the treatment group, they have some outcomes, and patients in the control group, they also have some outcomes, the same outcome. And so we denote Xi an outcome in the I subject in treatment T, and Yj the same outcome, but in the J subject in the control arm. And we're going to compare all the Xis to all the Yjs. How are we going to do this? Well, we're going to do pairwise comparisons. So this is very different from every other statistical approach that's been used so far, because in the sort of standard statistical approach, we take all the patients in the treatment arm, look in a sense at the mean outcome in these patients, and then compare this mean outcome to the mean outcome of all the patients in the control arm. And if the means differ, then we're done. We can claim that there is a treatment effect. Here, instead of looking at the mean or average over these groups, we look at the pairwise comparisons. So we compare each and every patient in the treatment arm and compare them to each and every patient in the control arm. So suppose we have 10 patients in the treatment arm and 10 patients in the control, that's 100 pairwise comparisons, 10 by 10, 100 pairwise comparisons. And for each of these pairwise comparisons, we can look at whether Xi is greater than Yj, in which case that particular pair of patients favors the treatment arm. Conversely, if Xi is less than Yj, then the pair favors the control. Sorry, there is a typo here. It should read favors C. And then if the same outcome is observed in both patients, then obviously the pair is neutral. It doesn't favor either treatment arm. Or sometimes we have missing data. Well, of course, if one of the two observations is missing, then the pair is uninformative. And so having done this now, we can do it for all patients. And so let me take a very simple example where we have 6 patients in the treatment arm, 6 patients in the control, and we look at their survival times, let's say. And suppose there is no censoring, just for simplicity now. So these are the survival times of these patients in months or years or whatever. The unit is pertinent. And so we look at the pairwise comparison. So this guy here has a survival time of 3 months, and that these 2 patients have survival times of 3 months. So these pairs would be a neutral. They would show the same survival times in both groups. Likewise, this patient here has 9 months observed survival time, these 2 patients. Also, we have another 2 pairs that are neutral. 4 pairs are neutral total. If we look at the favorable pairs, this patient survived longer than that patient here, 3 months versus 1. That's in favor of the treatment. And we do this for every possible pair, and we end up with 23 favorable pairs. Conversely, if we look at the unfavorable pairs, this patient has a 3-month survival, and that's unfavorable compared with that patient who has 7-month survival. And again, we do this for all pairwise comparisons, and we end up with 9 unfavorable pairs. So if we now put it all together, suppose we have no missing, so no uninformative pairs, we have 4 neutral pairs, 23 favorable pairs, 9 unfavorable pairs. How does that sum up? Well, we can do the sum of these percentages, and that shows a 64% of pairs in favor of treatment, 25% pairs that favor the control. So the net benefit, the difference between the two, is a 39% benefit in favor of the treatment. So the net benefit of proportion in favor is 39%. And so this is a measure of treatment benefit that's a probabilistic measure. There is a 39% net chance that a patient who receives the treatment will do better than a patient who receives the control. And so this is a bit of a statistical slide, so don't worry if you don't get the notations. But essentially what this shows is that by doing this, we've calculated a so-called U statistic. There's a general theory of U statistics in statistical theory, but in this case, it's really an easy one. The U statistic is defined as the sum over all the pairwise comparisons of the UYJ indicators, which we set to 1 if a pair is favorable, -1 if the pair is unfavorable, 0 otherwise. And we then divide this summation by m times n, which is the number of pairs, the total number of pairwise comparisons. And then the U statistic is indeed the difference between the proportion of favorable and the proportion of unfavorable pairs. It is the net treatment benefit. Just in passing, let me mention that Stuart Pocock, a British statistician, actually wrote a paper on where he proposed a statistic that he calls the win ratio, which is the exact same idea, but instead of looking at the sum, at the difference between favorable and unfavorable pairs, Stuart proposed to look at the ratio of these two quantities, and that leads to the win ratio. We're going to focus on the win difference, if you like, which we call the net benefit. Now, so far, I've considered the simple case where I have a single outcome. So you might think, well, why do we need to do this? We have perfectly okay methods to handle a single outcome. And the interesting observation is that even if we have a single outcome, we can use pairwise comparisons. And in fact, it's exactly equivalent in that simple case to the well-known statistical tests that we've been using all along. So in a sense, we are not innovating if we have a single outcome. We are just doing what we would normally do, except we look at it from a different angle. If we have a binary outcome, for example, what we look at is simply the chi-squared test. We look at every pairwise comparison. The pair is favorable if the treated patient has a success versus a failure in the control. It's the opposite if the patient treated has a failure, but the patient who is in the control group had a success. And of course, if we have 2 successes or 2 failures in a pair, that pair is neutral. And so in fact, in that case, the GPC test, the generalized pairwise comparison test, is not generalized at all because it's a single outcome and it's exactly equivalent to a chi-squared test. What about a continuous outcome, such as survival time without censoring? Well, if we look at the survival time and look at the pairwise difference, xi minus yj, we can actually look at it if we set up a threshold of 0. In other words, is there any difference between the outcomes of the patient treated and the patient in the control arm? If there is any difference, then we can claim that the pair is favorable or unfavorable, and we're back to the good old Wilcoxon test. Actually, Mann and Whitney, 2 statisticians, came up with a Wilcoxon test by using the pairwise comparison. So the GPC, the generalized pairwise comparison, is nothing else than a generalization of the Mann-Whitney test. Because now what we say is, why do we have to compare in a pairwise comparison xi and yj compared with no difference? Why don't we set a threshold of clinical relevance? Suppose, for example, in survival times that I say, well, I need to have at least 3 months difference in a pair of patients before I say, well, one patient really did better than the other. If I have a single day difference, I don't care. I mean, that's not enough for me to say that the treated patient did better than the control. And by using the threshold, we can in fact generalize the Wilcoxon test to any difference that we find to be of clinical relevance. And I will show this in the examples later. If we have a time to event outcome, the situation is slightly more difficult because now we have censoring. We have censoring, either observation, the xi or the yj, can actually be censored, in which case the comparison is a little more difficult. But we can take account of that, and Ed Guillen did that and generalized the Wilcoxon test when there is censoring of some observations. So we can use that approach as well. Now, what about multiple outcomes? Because this is really where I think generalized pairwise comparisons can help. Suppose we now have 2 outcomes, xi and x prime I in patient I in the treated arm, and yj and y prime j in patient j in the control arm. And so now we're going to do the comparison between these 2 outcomes. So the key here is that we have to prioritize the outcomes. We have to say X is a more important outcome than Y. So we're going to look at the pairwise difference between the patients in terms of X first. And so if X is better, for the patient treated than the control, we say that the pair is favorable. We don't even look at Y in that case. But if X and y, Xi and YJ show the same result for a pair, suppose that, for example, we look at survival time and then something else. If two patients are still alive, well, this pair is uninformative in terms of survival time. So we're going to look at the next endpoint or outcome, which is Y. And then we look at whether Y is favorable, favors the pair, favors the treatment or not. And if that's the case, then we say the pair is favorable. And so we have this prioritized outcome analysis where we look at every outcome of interest if and only if the previous outcome did not conclude that the pair was favorable or unfavorable. And so this is the generalized pairwise comparison in more general settings where we have more than two outcomes. We can also look at prioritized outcomes by looking at the threshold. We could say, for example, that I'm interested in patients whose survival times differ by more than 12 months. And if they don't differ by more than 12 months, then what about less than 12 months, maybe 6 months, maybe 9 months, maybe 3 months? And I can do this for every threshold that I find of clinical relevance. I can also look, and this is what I'm going to illustrate now, I can also look at survival as the first outcome. And then if the two patients are still alive or don't differ in their survival time, then I look at serious toxicity. And this is back to the example Everardo showed, where we have not just mild toxicities, but relatively serious toxicities, grade 3, 4 toxicities on the CTC toxicity scale. So let me illustrate this now quickly, because we want to leave some time for questions at the end of the talk. But let me illustrate this on the 3 examples that Everardo already showed quickly. Gemcitabine versus erlotinib in patients with advanced pancreatic cancer. Gemcitabine versus FOLFIRINOX, in other words, single drug versus targeted agent, single drug versus polychemotherapy, and then gemcitabine plus or minus nab-paclitaxel, so single drug versus 2 drugs. And so let me look at the first trial, the trial of erlotinib first. Everardo already commented on this trial. There was indeed a statistically significant separation of the survival curves, believe it or not. It's not immediately obvious to the naked eye that these 2 curves differ statistically, but they do because the trial was pretty large. And then, you know, the trial this hazard ratio of 0.82, but about a 10% difference between erlotinib and placebo against erlotinib. So what about using generalized pairwise comparisons to analyze these data? Suppose I'm interested in a survival difference of at least 2 months, and I'm going to vary this 2 months in the next slide, but let's now take 2 months, and then look at the worst toxicity of any type. So suppose a pair is favorable, a patient survives longer than another by at least 2 months, then the pair is favorable. I don't care about toxicities if that's the case. But suppose a pair is neutral. For example, 2 patients have a survival difference of less than 2 months between them. Then I'm going to look at the toxicities, and I'm going to claim that the patient who did not have a grade 3, 4 toxicity is the winner in that case. And so the pair is again favorable or unfavorable depending on not the survival difference, because that's minimum, it's less than 2 months, but based on the difference between the toxicities of these 2 patients. And so this is a more general way of looking at the data where I take account of the 2 endpoints simultaneously in my analysis. And so here is the table that was published by Julien Perron and colleague. And the table shows that indeed there is a 4.7 net benefit in terms of survival of at least 2 months in favor of erlotinib, but at the same time there is an 8.3 harm, if you like, net harm against erlotinib in the pairwise comparison. So in total, I get to a negative effect of erlotinib, a minus 3.6 net harm against erlotinib if I consider survival of at least 2 months. And as I said, I can do this for any threshold in the survival difference. And if I do this for many thresholds, as is shown here, if I put the threshold as 0, which is what the conventional analysis would do, then indeed I have a benefit in survival, a net benefit of about 5%. So there is a net probability that a patient treated with erlotinib will do better than a patient on the control arm. 5% probability, net probability of doing better. But there is also a lower percentage of a low probability of a benefit if I account for the toxicities, for the grade 3-4 toxicities that are due to the treatment. And so if I now change the threshold for the survival difference, obviously, because I increase the threshold, then the incidence of the toxicity on the analysis, or the impact of the toxicity on the analysis, will grow, because I become more and more demanding. As you see, the net benefit doesn't change much. It remains close to 5%, which isn't much, by the way. But because of the toxicities, the differences in toxicities, now I have more and more pairs that show, in fact, that the treatment is unfavorable for that difference in survival because of the toxicities, the additional toxicities of erlotinib, such that I have a net benefit of erlotinib initially, and I have a net harm of erlotinib. It's even statistically significant against if I put a threshold of clinical relevance at 5 months. So all in all, this shows that erlotinib, yes, has a survival benefit, but in fact, if you account for the grade 3-4 toxicities, that benefit is very quickly, in a sense, canceled by the harmful effects of erlotinib and the toxicities it induces. So it's interesting to compare, of course, the results we've just seen with the results of another trial, the trial of FOLFIRINOX versus gemcitabine. As Everardo pointed out, the benefit of FOLFIRINOX was much greater in terms of survival. It was a 0.57 hazard ratio, but again, there was around about a 10%, 9% difference in terms of grade 3, grade 4 toxicities here. But as you can see, the toxicities were not particularly against FOLFIRINOX, they were actually in favor of FOLFIRINOX. So if I now look at the differences in terms of the generalized pairwise comparisons, I see that the net chance of a better outcome here is very close to 30%. It's 0.27 here, 27% net benefit. That means a patient who receives FOLFIRINOX has a 27% probability of doing better than a patient in the control arm. And as you can see, if I account for the toxicity, then in fact, the difference does not change very much. It doesn't change very much regardless of the threshold, and this is because the benefit of FOLFIRINOX is much larger on survival. So even if I increase the threshold, that difference in toxicity that we observed doesn't really play out in the analysis. The treatment remains highly significantly in favor of FOLFIRINOX regardless of the toxicities. And finally, if I look at the gemcitabine plus or minus nab-paclitaxel Abraxane in, again, patients with advanced pancreatic cancer, again, we see a larger survival benefit. The hazard ratio is now 0.72. But here, the difference, unfortunately, is against the combination. Obviously, adding Abraxane to gemcitabine induces quite a bit more toxicities, grade 3, grade 4 toxicities. Actually, it's more than a doubling of grade 3, grade 4 toxicities. So again, you see that there is a benefit in survival, but at the expense of more grade 3, grade 4 toxicities than what we saw before. And as you would expect, if we look at the generalized pairwise comparisons, now in fact, the treatment benefit in terms of survival alone remains very comfortably significant regardless of the threshold. But if I take account of the grade 3, grade 4 toxicities, what I see is that I have a net benefit of paclitaxel up until 5 months, round about 5 months, and it's actually statistically significant up until round about 3 months. But if I go beyond 5 months, then unfortunately, the combination of gemcitabine Abraxane does worse than gemcitabine alone. And so these three contrasting situations show the benefit of actually accounting for the toxicities, not in an informal marginal way, but in an analysis that allows for it. I'd like to very quickly go through these slides, but I want to leave some time for questions. But just a word about non-proportional hazards. As you know, and as Everardo said, we often face situations of non-proportional hazards, and we can compare. This was done by Julien Perron and colleagues in a recent issue of JAMA Oncology. We looked at different situations of proportional hazards and non-proportional hazards, and here we compare the survival curves to the chance of a net benefit, or if you like, the net benefit of the treatment. And what we see is that with proportional hazards, the net benefit starts at a given value and then goes down to 0. If we look at early survival differences, we start from a higher point for the same hazard ratio, and we also go to 0. If we have a delayed survival difference, we start from about the same point in terms of the net benefit, but we actually go to, we actually stay, the net benefit remains at a higher level than before. And if we have a cure rate, in fact, it can be shown analytically that the net benefit goes to the cure rate. So if we have a 10% difference between these two survival curves, likewise, the net benefit will actually asymptotically go to this 10%. And so, in fact, it shows that the net benefit is really equivalent to an analysis of survival, but is perhaps and hopefully more informative in some situations. How about the power of the test? If we compare the power of the log rank test with the power of the GPC approach, well, obviously the log rank test is uniformly better. The yellow curve is always better than the blue curve. But if we have delayed treatment effects, as in immunotherapy, then the GPC approach has better power than the log rank. If we put the threshold of clinical relevance far enough in time that we begin to see the separation of the survival curves. And likewise, if we have a cure rate, then the GPC test actually has better power than the log rank. So I'm going to leave it as that because, as I said, we really want to leave time for questions. But let me conclude by saying that we believe that the benefit risk assessments that are currently being done really raise issues because they are marginal. They look at benefit endpoints and risk endpoints separately without accounting for the correlation between these outcomes. GPC, generalized pairwise comparisons, naturally account for the correlation because they look at pairwise comparisons. So they look at individual patients, which is very different. But of course, the cost or the price you have to pay for this is that you have to prioritize the outcomes, which may be a problem. In statistical terms, as I mentioned, GPCs are equivalent to standard non-parametric tests. So we don't invent something completely new here. We just generalize our methods. They may have better power than the log rank, and they allow for testing of clinically relevant differences, which I believe goes into personalized medicine. So with that, thank you all for your attention, and we will be happy to entertain questions.
Well, thank you very much for your insightful presentation. Now I would like to invite our audience members to continue sending in their questions or comments using the questions window for the Q&A portion of this webinar. I've already received a few, so let's start with those. Our first question here is, are these methods accepted by regulators in their decision-making?
Everardo, I can probably give this a shot. No, no. The answer is simple. These methods are, as you've seen, pretty new. They've been developed over the last years, and so at this time we have no, absolutely no regulatory exposure yet.
Okay, and our next question here is, what is the point of view of the authorities about the GPC approach?
Likewise, it's the same question really, and I would answer the same way. I think we have to make these methods more available, and this is done through publications and presentations, but it obviously will take time before the agencies even begin to look at these methods.
All right, thank you for that answer. Our next question here is, can the GPC methodology be used to design a trial?
Everardo, I can continue since these questions actually really refer to GPC. The answer is yes. The short answer is yes. The long answer is yes with difficulties. Because the method, as I showed, is very general. Again, it is too general to be analytically tractable in all situations. And so if we want to use GPCs prospectively using 2, 3, or more endpoints, then obviously the problem becomes intractable analytically. The complexity of the method is such that it just cannot be handled analytically. And so we would have to do this through simulations. So a simulation-based design approach would be warranted. And this is obviously, this requires work. It requires a software to do this. And so we're not there yet. So again, it's a very good question, thank you, but we're not there yet. We need to develop the methodology for doing simulations and be able to indeed design trials using this.
Thank you for that answer. Our next question here is more for clarification. It says, I don't understand how you address correlation. You only get to compare secondary endpoints where there is a tie on the primary endpoint.
Yeah, that's actually quite a good question. It's a very complex question statistically, because indeed we do not account for the correlation directly. What I meant to say, and I perhaps should have said it better, is that because we look at individual patients and compare individual patients, we in fact implicitly account for the correlation, but in a very special manner, because as the person who asked the question pointed out, we will only look at the secondary endpoint if the primary endpoint shows a neutral pair or an uninformative pair. In that case, we move on to the next secondary endpoint and so on until we've reached the end of the list. So in a sense, we don't look at the correlation per se statistically, but we look at the association between the endpoints indirectly by looking at secondary endpoints if and only if the primary endpoint isn't sufficient to classify a pair. So getting back to the example I mentioned, suppose that patients who have a survival benefit also experience a grade 3/4 toxicity, which is very often a situation that we encounter in cancer. In oncology, it's not uncommon that clinicians will accept toxicities as being a mark of efficacy. They say, well, a patient who has toxicities, you know, maybe it's not proven, but maybe will also benefit from that treatment because the drug obviously has an effect. So in a sense, in some situations, the toxicity is a surrogate for the efficacy of the drug. In that case, if the effect is sufficient on the efficacy endpoints, we will not look at the toxicity outcome for the patients who benefit a lot, but we will definitely look at the toxicities for patients who do not benefit or benefit only a little. And so in a sense, we will do what conventional analyses don't do, which is to look at the within patient comparison of outcomes, not the comparison of the means.
Thank you so much for that answer. Our next question here is, has the GPC method been used in a benefit-risk discussion with authorities?
I'm going to ask that again by a no. It's similar to the first questions we received, and you know, there is again very little experience, but maybe Everardo could add something from the point of view not of the FDA or EMA, but of the point of view of you know, the NICE or similar organizations that look at the pharmacoeconomics of drugs and look at the benefit cost analysis rather than the benefit risk. Everardo, did you want to chime in on the health technology assessment agencies?
Yes. Well, I don't know of a situation where the method has been used. Like we discussed, I think it's one of the potentials for the method, and it would be a way to sort of formalize decisions, at least based on formal statistical analysis and comparisons. But to the best of my knowledge, the current scales, for example, the ones that I mentioned, or the things that I usually see in the oncology literature about benefit risk, do not do that. So the strict answer to the question is, as far as I know, it has not been used.
All right, thank you so much for those answers. Our next question here is, for which type of treatments would GPC be potentially beneficial, useful for retrospectively analyzing trials?
Mark, you want to tackle that?
No, go ahead. I'm thinking. Good question.
Oh, well, I heard you say that we prefer randomized trials, but there is no, at least at least, I mean, it can be applied. The methodology can be applied if you can come up with pairs to compare. But of course, we prefer randomized evidence. And Mark, correct me if I'm wrong, the team has not yet used it for situations other than randomized trials, right? Or do you know of anyone?
We haven't. Actually, I know of other people who now begin to use generalized pairwise comparisons for non-randomized situations, particularly in more general healthcare problems, comparing, for example, hospital policies and stuff like that. So there is ongoing work on this aspect of the problem, and obviously, the minute you compare two groups, you can use generalized pairwise comparisons. It doesn't have to be in the context of a randomized trial. But we, as you said, Evrado, we ourselves tend to be a bit obsessive about randomized trials. So that's all we care about, quite frankly. But I think the question went a little beyond that. I think the question was really about what situations more specifically would be good cases for using GPCs, as opposed perhaps to situations in which conventional analyses do the trick perfectly. And let's be frank, I mean, many times you can use a standard method of analysis, which is perfectly okay. I think GPCs, it will only add in that case to the standard approach. But there are situations, and the ones I've just shown in pancreatic cancer, where you have this difficult trade-off between a potential gain in survival, albeit not a very long prolongation of survival, and really serious toxicities that bother the patient and make their life, in some cases, miserable. I think that's a real trade-off situation where we need to do a better job than what we do at the moment, I think, and especially in informing the patients. I think GPCs have the potential of perhaps showing the information to the patient in a manner that they will understand, because they have a hard time, and I would have a hard time understanding the hazard ratio and then differences in proportions of toxicities. Now we have a method that allows us to show the result of the trial on a single scale, which is the net chance of a better outcome. I'm not saying it's completely easy to understand, but it's at least, in my view, not more difficult than the traditional methods we use.
Thank you so much for that answer. We have another question here from an audience member, and it is, how about analyzing trials with 3 or more treatment groups?
Oh, that's a good question. Yeah, here, because of the pairwise nature of the comparisons, we would actually have to look at the pairwise comparisons. If we have 3 treatments, that gives us 3 potential comparisons. And by the way, this is also, in many cases, how we analyze 3-arm trials, is by looking at the pairwise contrasts between the treatments. We could also look at, for example, if we have 1 control and 2 treatments, we could look at the control versus the combined treatments. That's also done conventionally. So I don't think that we would do it differently from what we have to do anyway. The only thing that we couldn't do, obviously, is a model where we have the 2 treatments and the control arm, let's say in the situation I just mentioned, in the same model. Here we would have to do it using a pairwise approach, obviously. So it's a good question. That's in some cases you need to use models, and in those cases the pairwise comparisons will not be able to address the same approach.
Thank you for that answer. Our next question here is, would you say that in GPC analysis, the primary endpoint is a, in quotations, gatekeeper?
Yes, I mean, gatekeeping procedures are very specific procedures, as probably the caller knows. So I do not want to confuse people by saying, yes, this is the same as a gatekeeping procedure, because it's not. The gatekeeping procedure is typically a procedure to split the significance level between several comparisons. So in that sense, this is very different, but the concept, in a sense, is also one of gatekeeping. You only look at the secondary endpoint if you have a pair that doesn't tell you anything about the primary endpoint. So in that sense, it's gatekeeping too.
All right, so we have enough time for just one more question here, and that question is, how do you choose your pairs?
Well, you don't, because you look at all of them. And by the way, one thing we didn't mention, just in passing, if we have a stratified design, then obviously we only look at pairs within strata. And so we can easily stratify the analysis just as we would in a conventional statistical approach and do the pairwise comparisons within strata. But other than that, we don't choose the pairs, we use them all.
All right, well, thank you very much for those answers. We've reached the end of the question and answer portion of this webinar. If your question wasn't attended to during the Q&A session, the team from IDDI will do their best to follow up with you after this webinar. Thank you everyone for participating in today's conference. You will be receiving a follow-up email from XTalks with access to the recorded archive for this event. A survey window will be popping up on your screen, and your participation is appreciated as it will help us to improve our webinars. Now, please join us in thanking our speakers, Mark Boyce and Everardo Saad, by sending a message in the chat panel. We hope you found this conference informative. Have a great day, everyone.